This portion of CardioSource Video News is supported by the makers of Xarelto.
Welcome to Chicago, where it's the final day of the ACC.12. I hope that you've enjoyed the meeting. We certainly have. It's my pleasure again to bring the A-Team panel to you to talk about really today's late-breaking clinical trials and really an overview of the meeting. Dr. Chris Cannon, who many of you know. Chris is professor of medicine at the Harvard Medical School and the senior investigator of the TIMI study group at the Brigham and Women's Hospital. And Dr. Paul Douglas. Paul is the chief of cardiology at the Atlanta Medical Center. Both are outstanding cardiologists and good friends, so welcome to the panel. Chris, why don't you start us off with one of the late-breaking trials that caught your attention?
Well, the one that I think may change the way patients are managed in the emergency department is the ROMICAT trial that looked at the use of a CT angiogram as a strategy to rule out the presence of coronary disease. So traditionally, there are of the 5 million people who present, we'll put them in the OBS unit, do serial biomarkers and a stress test, and that takes a lot of time. Or if one moves quickly after an EKG initial biomarker to a CT angiogram, you could then rule out coronary disease quickly. And so they in fact found that they could discharge nearly 50% of patients straight away from the emergency department and cut down the length of stay that people were in there. It is a balance, though, that they do pick up more anatomic disease.
Absolutely, yeah.
Not too much, so there was more, testing, but I think a very promising new thing that this may become something that emergency departments would turn to in selected patients or as a general strategy.
Paul, your thoughts on it?
Well, I think this is a wonderful addition to our armamentarium. Helps us to identify people who are at risk very early on. The concern that I have, though, is that these were low-risk individuals, right. And so they did undergo more testing, and so the question is that the way we want to utilize our resources on people that we know are low risk? And yes, we can identify them pretty accurately, but is that where we really want to spend our financial resources? And so that's the only issue. You know, the fact that the cost differential was made up by the fact that they were able to get out of the hospital sooner, I think is in favor of this approach. But again, these were low-risk individuals.
Right. Okay.
Well, I think, one nice thing is that it's been also talked about in the outpatient setting and much maligned. Here in an acute setting, I think this opens the door again for emergency departments to figure out what were their pathways, what fits. Not everybody this new pathway, but I think opens the door to have another way of evaluating patients.
And with the tremendous utilization of emergency rooms for so many things now, it certainly makes sense. Paul, yeah. There was another trial that looked at pulmonary embolism and thrombolysis. Tell me a little bit about that.
Well, the issue with pulmonary embolism, and most of us would agree that people who come in with pulmonary emboli who are hemodynamically compromised are candidates for thrombolytic therapy. But that is not a very commonly used approach to these patients. And so this trial, the MOPETT trial, looked at low-dose thrombolytic therapy and compared low-dose therapy to the usual treatment to see if we could, in fact, lower pulmonary artery pressure, and then looked at recurrent PE right. and pulmonary hypertension as a secondary endpoint. And so this was a nice trial. Rather than using 100 milligrams of TPA, they used 50 milligrams of TPA, lower dose concomitant anticoagulant therapy, right. and they were able to demonstrate that they could significantly lower the pulmonary artery pressures, and there was a trend towards reduction in recurrent PE
so
mortality.
I mean, people are fearful of bleeding with high-dose TPA, and what was your take on this?
I agree. I think this is very promising. It's been seen in other settings. There's it's not a zero risk of intracranial hemorrhage. This was a modest study, about 120 right. patients. But these patients are very high risk and do have long-term consequences. So it's a nice, safer way to try and get a better improvement in the PE and its consequences. So I think this may also get into practice.
That's super.
And the one thing that this also demonstrates that those patients who were treated with TPA actually were discharged from the hospital sooner. So again, potential cost savings.
Early discharge.
Early discharge, that's what we're
Okay,
at.
I mean, it's the key. So Chris, let me jump back to you. There was another, the immediate trial. Is that tell me a little bit about that?
Yeah, you know, this one was the glucose, insulin, potassium, or GIK cocktail. Has been studied pretty extensively in hospital. This was a look pre-hospital to see whether it could help. In theory, it rests the myocardium. And they tried to see whether that could decrease infarct size. It didn't. They found one or two secondary endpoints that looked a little different, but not sure that this will make it into practice.
Paul?
No, you know, we've been looking at GIK for quite a while, and this is a...
almost since we were in medical
exactly.
school,
You know, this is going to date me, but I remember when these earlier trials were done. And we still, you know, can't find anything that is really substantially beneficial with this approach. I mean, I think that it's wonderful that we're looking at this as a potential therapy that could be offered in the field as you identify people, and maybe that may help reduce sudden death. There's some questionable benefit there, but again, this is an idea that just keeps coming back, but no real significant data to convince us that we need to change our
I know
approach.
we want to get to another one, but any idea why this doesn't work? I mean, methodologically, I mean, you know,
Well, it's a balance. You're trying to provide a substrate to the myocardial cells that are ischemic.
Right.
At the same time, that glycemic balance, sometimes you get hyperglycemia, and so that may be a counterbalancing issue. So not clear.
Okay, good. And tell me about, there was another trial, the ASCERT trial.
Well, this is a study from the registry. So it was a linking up of the NCDR registry looking at the age-old issue of PCI versus CABG. I think they utilized the databases well, seemed to find an advantage or lower event rates amongst those who'd been selected for CABG. And these are of the total group of patients undergoing revascularization. It's a little hard, frankly, to know which patients were being studied and does this really change what we know, where generally sicker, more diffuse disease is CABG, and so I'm not sure how this will change, but nice to see utilization of the big database.
That's great. Paul?
Well, the one thing that I think that this does help us do is legitimize the fact that we can use large clinical databases and combine them with administrative claims databases and really come up with a trial result that really is relatively in line with the previous observational trials and randomized trials that we've done in the past. And so the result here is similar to what we saw with Syntax trial and other trials.
You make a great point. It's a good use of the databases and everything else.
Yeah.
So I think that's great. All right. Well, we're gonna come back in just a second. I want you guys to be thinking about, sort of, as you look back at the meeting, what were your highlights of the meeting, and we'll be back after a short break. So be sure to join us.